with the eyelid tumors, and I request Prerana to talk about masquerades in eyelid tumors and eye out for eyelid tumor.
Good afternoon, everybody, and especially a warm welcome to everybody who decided to bunk the quiz and listen to this really, really interesting session. I promise you will get quite a bit out of this, and it will be a big different. It will make a big difference to your practice. So, thank you, Dr. Swati, for inviting me to this interesting symposium. Basically, my talk is to discuss a couple of masquerades or masqueraders of eyelid malignancies. So, while I was contemplating on what to speak about this topic, I've kind of distilled to giving a lot of clinical signs and information and cut out on all the fancy treatment options so that everybody can use this back in their clinic. Great. Perfect. So before we start, I'm starting with this gentleman. He's a 63-year-old male who presented to me with a persistent nodule over the left lower inner eyelid since the last 2 years, and he's had 4 surgeries done for the same, for this persistent chalazion. Does this raise any kind of red flag in your mind? What do you think? Something looking as indolent as this. It's just a small nodule at the inner corner which looks typically like a chalazion except for that one blood vessel over it. So what ideally you would want to do next is at least a thorough clinical evaluation. So on eversion of the eyelid, what I could clearly see was, so the blue mark over here, the arrow, is the normal meibomian gland openings which are whitish dots, and suddenly medial to it over the mass you see that those openings are lost. There are blood vessels crossing over to the mass, so these are feeder vessels, and the star marked is something I want you to focus on. So a chalazion can be cystic and it will elevate the conjunctiva over it, but this star mark is a demarcation that on palpation was firm, which was showing that the mass is actually infiltrating laterally also into the tarsus. Even on gross examination over the skin, the reddish area that I've marked is the infiltrated part which appears as thickened eyelid over there. So what looked like a chalazion had all of these features of loss of glands, but the most alarming sign here is something that's been operated 4 times for chalazion elsewhere should ideally be biopsied. So even if it's a chalazion that's come back after one surgery, ideally you should have your flags up and a low threshold to biopsy it. So this came out to be a not so poorly differentiated sebaceous gland carcinoma that was also invading into the conjunctiva around it. Similar case scenario, a very young lady, she's only 48 years old, who presented again with a persistent chalazion. So this is another case scenario where you evert and you see what looks very placid with yellowish nodules over it, goes into the tarsus and is covering the eyelid margin as well. Ideal case scenario for sebaceous gland carcinoma would be do an incision biopsy, and based on the extent you can even take more samples from around called map biopsy. Do a whole body PET scan with wide excision treatment under margin control and reconstruction, or first you downsize the tumor with chemotherapy. Based on the histopathology, you may need adjunctive radiation. The reason I'm starting with sebaceous gland carcinoma is because that's the one that we see most commonly in our Indian case scenario, and there's not enough literature in the West to support what we see over here. So when you get these kind of cases that are masqueraders, instead of just blindly going in and going with the first feeling that you get that maybe this is a chalazion, it would be ideal to be cognizant of what features are normally seen in suspicious lesions. So when you have destruction of eyelid architecture, as in these cases, loss of eyelashes, telangiectasia, intrinsic vascularity, nodularity with everted margins, ulceration, bleeding, effacement of all the meibomian glands or tarsal thickening, your radar should be really high up there. Going to a second case scenario. Now this is a 67-year-old female. She was treated elsewhere for blepharitis. So you definitely see the right eyelid and you see some irregular thickening here. What else do you observe grossly, which needs a little fine eye? See the lid creases over the skin on the left eyelid and see the ones on the right. They are stretched. That signifies some kind of induration or infiltration. On eversion, what I found was a very typical clinical sebaceous gland carcinoma with yellowish edges over there going into the tarsus and extending beyond. Luckily, this was still localized, so she did well with a wide excision treatment and reconstruction. But some patients may be referred very late into your practice, and these conditions can offer morbidity, cause mortality, as well as the risk of metastasis. So we have to be very aware of these conditions. Going to another patient who came with ptosis and blepharitis. Now again, if you look at this droopy eyelid on eversion, what I found was a very typical papillary variant of something that we call as a squamous cell carcinoma. So this is how it looks. Not all the cases come on the skin side. Some of them actually come on the conjunctiva and may not even have keratinization. So it was being treated elsewhere as blepharitis, which was probably because of infection. That's what they thought, and that could have led to the ptosis. So he did well with a Cutler bed and is doing well at 2 years follow-up also. This lady came to me with thickening of the fornix and a nodule on the eyelid. On eversion, you see that there is the alteration of conjunctival surface. There is a papillary area over here. There is some variation in texture and induration. There's a mass in the fornix sitting over here, which is extending right from the eyelid margin and creeping onto the bulbar conjunctiva with raised epithelium. So was this really a papilloma or squamous cell carcinoma? So the earlier surgeon had referred thinking that this could be a papilloma and will do well on therapy. So on incision biopsy, there was a papilloma area and an invasive squamous cell carcinoma as well. And this lady is doing well. After 2 cycles of subconjunctival interferon, I decided to downsize because on MRI there was no extension into the orbit, luckily. And then she underwent a wide excision surgical resection. Similarly, another elderly male who had presented with a suspicious lesion, but here some telltale signs are there. You see that there is some loss of architecture. This whitish plaque I want to highlight is nothing but keratin. So this keratin made me really want to evaluate him further and biopsy this area, and it turned out to be an invasive squamous cell carcinoma. So though there was no loss of lashes and there was less intrinsic vascularity, but there are a couple of signs that should make you aware of these conditions. Now going on to a late presented case, this was again missed by some physicians and was being treated as blepharitis. Unfortunately, by the time this patient came to me, the mass had extended. It was an invasive squamous cell carcinoma, had extended into the orbit. So the crusting that you see on the lashes should make you look at all the surface as well, and had to undergo an exentration. Some of the sebaceous gland carcinomas and squamous cell carcinomas are known to spread over the surface along the epithelium, what we call as pagetoid spread. So in these cases, just an incision biopsy may not help. You want to know the extent. So you would want to sample a bit of all the areas. Coming to another very rare case, actually, this is not a common case. So this patient was being treated for over 3 years as multiple hydrocystomas. He started off with an upper eyelid lateral corner with a smaller cystic transilluminant nodule, and by the time he came to me, he was like this. So what do you think this is? This is an extremely rare tumor which usually comes out of the salivary glands, very rarely out of the lacrimal gland. It's a mucoepidermoid carcinoma of the eyelid. By the time he had reached me, I explained and counseled him about the prognosis of the condition, but he was lost to follow up and he refused treatment after this. So what are these eyelid masqueraders and why should you know about these? Basically, any malignant eyelid tumors which present with signs that make you think that maybe these are benign conditions, most commonly as chalazion or blepharitis, sometimes as cysts or papillomas. These could have underlying malignancy, so look out for the suspicious signs. Why should every ophthalmologist know about these? Because the management and prognosis will differ based on when you refer them to an oculoplastics or a super specialty center. The suspicious signs, I've already shown you the slides. And you should always have a low threshold for biopsy. It may come out to be non-malignant, but always biopsy them. This is the last trivia. So considering this is masquerade, sometimes benign conditions can masquerade like malignant. So this is a 1.5-year-old child who presented with this eyelid nodule. And this was there on incision biopsy. Any takers for this? What are these cells? So these are Touton's giant cells which you see in juvenile xanthogranuloma. The biopsy had not taken from the eyelid. He had similar lesions on the neck and the back. So that was biopsy. So these patients do well with intralesional steroids. You need not go ahead and think it's a malignancy and go all out. Similarly, this last case, this turned out to be a pseudoepitheliomatous hyperplasia. And the sign which told us this, or the risk factor, was he was seropositive. Thank you.